Good evening, everyone. I am genuinely excited to see so many of you here today. This is Nandini Paul, and I'll be your host for today's UDAAN session. And I welcome you all to today's session. So, let's begin. Let's start with something very real. Imagine you are in a clinical setting and a burn patient is brought in. Panic everywhere. And someone looks at you and says, "Start the management." What would you do first? Because in that moment, it's not about the theory anymore. It's about the clarity, speed, plus the correct action. And that's exactly what we are going to build today. Today's session is on burn management from first aid to recovery. But let me tell you why this topic actually matters. This is one of the topics where questions are predictable, concepts are interconnected, and mistakes are very common. So, if you understand this properly today, you will save yourself multiple questions in the exam. Okay, so this is what you will get in next 60 minutes of this session. We'll begin with the introduction of NNL, then introduction of speakers, then the scientific topic, which we are catering today, burn management. Then we'll hear from our NORCET topper and our Margdarshak, and then we will round up. So this is all about NNL1. What is NNL1? Nursing Next Life, now redefined as NNL1, is an affiliate of CBS Publishers and Distributors Private Limited, a pioneer in health sciences publishing known for its visionary approach and impactful contributions to academic excellence. After establishing a robust presence in the publishing industry, CBS ventured into the nursing edtech space with a mission to deliver high quality nursing education accessible anytime, anywhere. Launched in August 2020 as Nursing Next Live (NNL), the platform was created to bridge the educational gap between medical and nursing domains. Today, NNL1 has evolved into a comprehensive learning ecosystem catering to the diverse academic needs of nursing students, ranging from undergraduate programs to competitive examinations such as NORCET, NCLEX, and MSc Nursing. All content is aligned with the latest INC syllabus and curated by leading experts in the medical and nursing fields to provide a future ready learning experience. With a steadfast commitment to advancing nursing education, NNL1 has expanded its scope beyond online learning, having successfully established itself in the online education domain. NNL1 now has ventured into offline education with its first physical center in Noida, Uttar Pradesh, where two batches have already achieved promising outcomes. In 2025, NNL1 is proud to launch its first satellite center, NNL EduHub, in Jaipur, Rajasthan. Our offline initiative offers an enriching blend of classroom learning and interactive sessions led by esteemed educators. Students benefit from state of the art facilities, including a CBT lab, simulation based clinical training, in person doubt clearing sessions, certification programs, and personality development modules. This holistic approach ensures that students gain both academic excellence as well as practical proficiency. These are the reasons why students choose NNL1, and it's the first choice for a reason. We have 7,500 plus selections in AIMS NORCET through Plan C+, Plan QB, Fast Track, and NNL Academy over the last 5 years. This is the reward which you will get after this session. If you attempt the quiz and you win, you get a chance to win this Masterstroke Volume 3. All right, let's go into the most important part. We have with us someone who is known for making complex topics feel actually manageable Ms. Priyadarshini Balan. She has done MSc in Medical Surgical Nursing with a specialization in critical care nursing from Sri Balaji Vidyapeeth University. She will be taking you through burn management in a way that connects clinical understanding with exam logic. I welcome Ms. Priyadarshini ma'am to this session.
Thank you.
Then we have our Margdarshak with us, Ms. Tuti Singh, who has got AIR 480 in NORCET 3. She is currently working at AIMS Rabeli. I welcome you, ma'am.
Thank you, Nandini.
And next up, we have NORCET 9 rank holder, Ms. Purabhi Paul. She is graduated from College of Nursing, Medical College and Hospital, Kolkata, and currently she is working at AIMS Deoghar. I welcome you, Purabhi.
Thank you, ma'am.
Okay, now let's begin with today's topic, burn management. It will be taken up by Ms. Priyadarshini ma'am. So, ma'am, the stage is all yours.
Yes, I hope the screen is visible to everyone.
Yes, ma'am.
Yes. So a very warm good evening to everyone. And I really want to congratulate the students who are present over the webinar, those active candidates, those advanced learners who feel self-motivated to learn certain things, right? So today's topic which we're going to discuss is the burns management, one of the most important topic. So the topic will be going in a NORCET-centric aspect. But apart from thinking about competitive examination, it is very, very important to know learning about certain topics is very, very important to be a clinical nurse. So if you are into a practice or if you are a student, okay, learning about burns management is an integral part of your journey, right? So here in this topic, we're going to learn all the advanced level of burns management, okay, which you have to definitely know as a clinical nurse, right? So what is meant by burns? As you all know, generally burns is any damage to your tissue or your skin, basically. It may be by means of any form of thermal injury, that is because of heat, because of electricity, because of a rapid friction, because of radiation, or even because of chemical. So anything which is causing damage with the thermal activity, that is termed as burns. So managing burns is a very, very crucial aspect. In the first 24 hours, when the patient is having more than 10% of total body surface area of burns, the first 24 hours play a pivotal role in managing that particular patient and also to save the life of the patient. So to save the life of the patient, it is very, very important to know what are all the steps you should follow, right? So first and foremost, we are going to discuss about what is the referral criteria to a burns unit. So when I'm referring the patient specifically to a burns unit to get managed over there, right? First is the burns involving the critical body areas. You can get the question like except factor question where they can ask like in which of the category you will be shifting the patient to burns unit or referring the patient to the burns unit. You have to remember the critical body parts has been injured, which includes your face, hands, feet, genital region, perineum, or your major joint is involved. We have to definitely refer the patient to the burns unit for specialized care. In case of chemical burns, regardless of the total body surface area which is burnt, okay, irrespective to the total body surface area which is burnt, which we are calculating with the help of rule of 9, irrespective to that, we are going to take that patient into the burns unit and for the management, right? So next is electrical burns. Any form of electrical burns, as you all know, this is going to cause a deep damage to all the tissues. And electrical burns can cause severe form of arrhythmia, right? They can cause severe form of rhythmic changes in your heart, which is going to be life-threatening. And it also can lead to your myoglobinuria. So inhalation injury, again, the most important part. Whenever the patient is with inhalation injury, we are suspecting the patient airway can be compromised. So it is very, very important to monitor the airway to the patient who is having inhalation injury. And we have certain important key pointers which you can analyze whether the patient is a case of inhalation injury or not, right? So regardless of the skin burn size, when the patient is into an inhalation injury, we are going to specifically shift them to the burns unit. So chemical and electrical burns, always we have to refer regardless the total body surface area which is covered, right? So next we have the partial thickness burns when it is greater than 10% of your total body surface area, which we are calculating with the help of rule of 9, then we are going to shift the patient to the burns unit. So full thickness burns, if it is a third degree burn, as you all know, based upon the involvement or the depth of the wound, we are categorizing it as first degree to fourth degree, right? So when it is a full thickness burn, okay, when it is a third degree burn, any patient with any age group, you are going to shift them to the burns referral unit. Then extremes of ages, okay, if the patient is an infant patient or if the patient is an elderly patient, which means here based upon the vulnerability, okay, when the patient's age is so vulnerable, either he is an infant or either he is an elderly person, old age person, then you're going to refer them to the burns unit for the management, okay? And significant comorbidities, and this is also a very, very important point. A patient is immunocompromised, a patient is a case of DM, and if a patient is having any form of cardiac or renal disease, because once the patient is getting the burns injury, there will be provoking of this following symptoms in cardiac, renal, and the patient will be having activated immune system. So in these cases, we are going to definitely shift the patient to the burns referral unit. This is a very, very important slide. 2 slides are very, very important, right? These are the referral criteria which we have seen. You have to see definitely if the patient is coming under such criteria, you're going to shift them to the burns unit for a specialized care. Now comes the most important part. Whenever we talk about burns management, we will be going in an approach of ABCDE approach, right? So all burns patient has to go with this particular approach. So as A is given, A stands for your airway. As I said, inhalation injury, irrespective to the total body surface area or any external skin affected, we are going to shift the patient to the burns unit, right? So assess for inhalation injury. How we are going to assess the patient is having a inhalation injury? You have to look for singed nasal hair, which means there will be darkness and there will be burnt of the nasal hairs. And the patient will be having harsh voice because of accumulation of the carbon monoxide components into the airway. Then carbonaceous sputum. You can see blackish sputums which is stained because of that suffocation. Then closed room exposure. Always remember, whenever there is an inhalation injury, right? If the risk of this inhalation injury will be getting greater and greater when it is a very close room. For example, I am sitting inside this room, some burns is happening inside this room, I'm feeling suffocated, and what will happen? Because of my panic and anxiety and everything, I will be hyperventilating. This hyperventilation by me causes over inhalation of that particular component. Okay, so that causes even more severe symptoms. So any positive signs of the singed nasal hair, hoarseness of voice, and carbonaceous sputum, when the patient is splitting the sputum and you can see dark components, blackish tarry components, then you are telling it is a case of inhalation burns. So you have to start the prophylactic intubation to prevent a progressive airway collapse. So primarily, as I said, whenever the airway is affected, the primary component which you have to focus, if the patient is hemodynamically unstable and he can't breathe effectively by his own, definitely we have to stabilize the airway through the intubation. All right. So next is breathing. Assess for hypoxia. In case of carbon monoxide poisoning, you can see the classical feature of hypoxia. In ABG also, you can see there is a fall in your PaO2 and SpO2, right? And the eschar constrictions around the chest restricting ventilation. As you all know, when the patient is a case of severe burns, okay, where he's going for full thickness or partial thickness burns, a deep thickness burns, what will happen? there will be an eschar formation. Well, you know what is eschar? Like the tissues will be stiffened because of that burns wound. So in those cases, what will happen? This can lead to the compromisation of the ventilation. Okay, it cannot allow a proper chest expansion. So in that case, what we have to do, we will be performing an escharotomy, right, where we make a slit incision and make that area quite stretched so that it will be easy for the ventilation. Right. So the most important management, if you see the case with hypoxia, if the patient is stable, you're going to administer 100% oxygen. If the patient is not stable, immediately you're going to start the intubation. So administer 100% oxygen via a non-rebreathing mask, and you have to monitor the SpO2 and respiratory rate continuously so that you can see the progress. Even after administering 100% O2, if the patient is not maintaining the SpO2 of greater than 90%, definitely you have to shift the patient for intubation. Next is circulation. You have to assess for fluid loss and capillary leak. As you all know, the first and foremost happening or pathophysiological happening which is happening in your burns is, first and foremost, there will be a shift of fluids from the intravascular space to the interstitial spaces, right? To the interstitial spaces, as you all know. So here we have a detailed flow, what is happening. So first is when the burns is going to be greater than 10% at 10% of your total body surface area, according to your rule of 9, the first and foremost thing which happens is the systemic inflammatory responses, which means your bradykinin, your cytokines, interleukins, prostaglandins, all these inflammatory mediators will be hyperactive and they will be releasing to the greater extent. So if that particular inflammatory mediators are released in greater extent, the primary happening what happens is the intravascular space. Okay, or to be very specific, you can think about the capillaries. The capillaries will be becoming more permeable. So what is meant by capillaries becoming more permeable? As you all know, capillaries are so properly placed and they will be allowing only certain amount of fluids to shift outside into the interstitium. But here, because of the hyper response of the inflammatory mediators, what will happen? The capillary leak will be more. The capillary will be becoming more permeable and it will allow lot of fluids to come out and leak out into the interstitial space. This is what we are telling as the third space fluid loss. So what is meant by third space fluid loss is leak of intravascular fluid into the interstitial spaces, which means even though a good amount of fluid is there, after it is leaked to the interstitial space, it is useless. Okay, body will not do any hemodynamics with the fluids which is present in the interstitial space. So as this is going to happen in the first 24 hours so rigorously, what is going to happen? Keep on the fluids is going to release and leak into the interstitial space. So what will happen? Obviously, in the intravascular space, which means inside the blood vessel, there will be reduced amount of fluid, which means reduced amount of blood. If there is a reduced amount of blood, obviously you can see the systemic symptoms of hypovolemia, where the cardiac output is going to be reduced, right? The patient will go for hypovolemia and hypovolemic shock. Right? This is what is happening initially after the patient is going for a burns injury. So we have to initiate the IV fluid resuscitation. Here where comes the most important aspect. Whenever we think about burns management, the primary thing which comes into our head is the fluid resuscitation with the help of your Parkland formula. So here you will be knowing why I'm doing a rigorous fluid resuscitation, okay, in burns patient, because I have to maintain the intravascular fluid volume. So that is the reason in the first 24 hours, I am starting an drastic IV fluid resuscitation, right? Yes. So next, after D stands for your disability. So you have to assess the Glasgow Coma Scale, right? And you have to assess the consciousness of the patient. And in most of the cases, if the patient is unconscious, okay, there may be a the total body surface area may be more greater, or it is indicating the primary indication will be going for your carbon monoxide poisoning, right? And the patient is going for severe hypovolemia or associated with head injury, then you will be having a GCS changes in coverage of more total body surface area. And you have to monitor for the pupillary size and reactivity to find out any neurological symptoms, and you have to manage the airway. If the GCS is less than or equal to 8, you have to immediately secure the airway with the help of your intubation. Next is exposure. Remove all clothing and jewelry. And the most important thing is if certain cloth, when they are burnt, okay, and while removing it is going to cause severe injury, those kind of cloths we are not removing. Those cloths we are placing and we are doing the management. Whichever is easily removable, you're going to remove it, right? And you have to estimate the total body surface area using the Village rule of 9, one of the most important tool which is used to analyze your total body surface area. We have another rule also, that is your Lund and Browder chart. So the most important thing, you have to know the differentiation between the two charts. Okay, both Village rule of 9 and London Browder chart are used in all the cases. But London Browder chart is going to be very specific and so intricate. But your rule of 9 is quite easy. That's why clinically it is vastly used when comparing to London Browder. But if they're going to ask which is the best method, then your answer will be your London Browder chart, right? So you have to identify the cause. If the patient is conscious, you can able to collect the data from the patient, the cause of the wound, because of flame, because of scald, because of chemicals, electrical injury, that you have to analyze. And you have to prevent hypothermia. Obviously, the body can't able to effectively maintain the thermostatics. So it is very, very important to prevent hypothermia. Okay, cover with clean sheet after the assessment, right? So you should not skip any point of assessment in this. To be very specifically, we are going to see suspected airway injury in burns. As I said you, burnt or singed nasal hair is considered to be the most significant sign that it is an inhalation suffocated injury, right? It indicates direct flame inhalation by the particular patient. Hoarseness of voice. Why we are telling the patient is going for hoarseness of voice? Because there is a supraglottic edema. As you all know, because of third spacing and everything, the patient's airway is also going to become edematous, right? If it is going to become edematous, the patient on assessment, you can see hoarseness of voice. Okay. Then, if you're not treating it effectively, it may go to complete obstruction of the airway as the edema is going to go bigger and bigger. Next is carbonaceous deposit in the sputum. As I said, you blackish deposits over the sputum. This is a direct evidence that some copious smoke the patient has been inhaled. History of closed room burns. As I said, this is very important in burns injury, in inhalation injury. When it is a closed room burns, okay, there is no proper ventilation, then higher concentration of carbon monoxide can be seen, right? So that has to be taken into serious consideration. And burns involving head, face, and neck, anatomical proximity to the airway, which can cause Eschars and can reduce the overall ventilation efficacy. And altered mental status or sensorium. Whenever the patient is a case of carbon monoxide poisoning, or he's going for hypoxia or any head injury or a vast injury, then we are telling the patient is going for an altered mentation. So it is very, very important to monitor the GCS. So what are the position, like immediate management which you will be doing in case of airway is affected, in case of inhalation injury? The first and foremost is the positioning. As you all know, this is a very, very common point. You are providing a semi-Fowler's position to the patient at the angle of 30 to 45 degree. Okay, primary aspect is to expand the lungs. Okay, and oxygen administration, as I said, 100% O2, you have to administer it via the non-rebreather mask immediately, and you have to reduce the carboxyhemoglobin half-life. So the most important point is, however, like how effectively you are administering this 100% O2 and reverting the patient SpO2. So you can reduce the efficacy of your carboxyhemoglobin half-life, right? And See, SpO2 monitoring. So continuous pulse oximetry monitoring you have to do. The SpO2 is unreliable in case of CO, carbon monoxide poisoning. So obviously you have to monitor for ABG level. In ABG, specifically your PaO2, PO2 and your SpO2 you have to definitely monitor. Right. And COHP is your carboxyhemoglobin levels you have to monitor. In carboxyhemoglobin levels also, there is an important key point. So when the patient is a non-smoker, okay, when the patient is a non-smoker, it is going to rise by 2 to 3%. But if a patient is a smoker, you can see the carboxyhemoglobin level will be even more, greater than 10%, it will be increased. Okay, this is a special consideration while monitoring the carboxyhemoglobin level. If it is a smoker patient, already he's multiple times he's exposed to carbon monoxide. So he will be having a drastic rise in the carboxyhemoglobin. So talking about humidification, humidified oxygen is to be given to prevent any form of mucosal drying and retention of your carbonaceous secretion into your bronchioles. And intubation readiness, always we have to prepare for RSI. What does mean by RSI? RSI means your rapid sequence intubation. Rapid sequence intubation. So what is meant by your rapid sequence intubation is specifically in RSI, the patient will be given with a cricoid pressure of 40 newtons to ease the intubation process. That is your rapid sequence intubation. Okay, and we have to prepare for it. And if edema progress rapidly, early intubation is always safer than a delayed intubation. Next is suctioning, a gentle nasotracheal suctioning you are going to perform to remove this carbonaceous secretion and prevent the lower airway obstruction and atelectasis further. Right? So the next is the most important slide. And we have an update also in fluid resuscitation. So in order to override the intravascular volume, okay, in order to make sure the patient is administered with proper fluid, we have to follow this fluid resuscitation principles. So primarily how we are calculating the fluid which is required for the patient is with the help of the Parkland formula. And now why I have written it is an old Parkland formula, because we have the formula updated here, right? So all the fluid, and here you have a key point, all the fluid measured from the time of burns, not at the time of admission. So I'll explain about this point even more detail to you people in the upcoming slide. But coming back to our old Parkland formula, as we all know, what is the old Parkland formula? It is 4 into your body weight, okay, patient's body weight into your percentage of total body surface area burned is equal to the total mol of ringer lactate solution you're going to administer in the 24 hours. As you all know, primarily we are going to administer crystalloids. Okay, primarily we are going to administer crystalloids, then only we are going for colloids. Right? Why we are administering crystalloids? Crystalloids are smaller molecules, right? It is very, very easy to stay within the intravascular spaces, right? And the shift of these crystalloids will not be so drastical when compared to colloids. If colloids are large molecules, if you're going to administer colloids in the first 24 hours, right? Always remember, colloids has to be administered after 12 hours only, right? So if before 12 hours, if you're going to administer colloids, what will happen? Already the capillaries are so permeable, these colloids will also leak, the larger molecules will also leak. So what will happen? Even more, the patient will become edematous. And coming back to the fluid measure from the time of burns, always remember, in first 8 hours, we are going to administer the 50% of the fluid. Right. This first 8 hours has to be calculated from the time of burns, not when you receive the patient. Right. For example, the first 50, like for example, the solution which has to be administered is 2000 ml. Right. So in first 8 hours, you have to administer 1000 ml. And in the next 16 hours, which means which means in 24 hours, from 8 hours to 24 hours, which means the next 16 hours, you have to infuse the rest of the 50% of the fluid, which means it is also what? 1000 ml. So if the patient is received after 2 hours, okay, the burns has occurred before 2 hours, and you are receiving the patient after 2 hours only. So you will be having 8 minus 2. Okay, that is 6 hours. So within 6 hours, you have to infuse this 50% of the fluids, of the crystalloids. Okay, always remember the fluid which you're going to administer will not be measured at the time of admission. It will be always measured with respect to your time of burns. If the patient is getting admitted after 2 hours, okay, you have to calculate the whole 8 hours. So 8 hours minus 2 hours, it will be 6 hours. Within that 6 hours, you have to infuse the whole 1000 ml. Right? So this is the case which is applied for if the patient is coming in 4 hours also, you have to rush the fluid administration within that particular first 8 hours. Right? So next, yes, just now we have seen the first half. Okay, the first half, which means the 50% of the fluid has to be administered in the first 8 hours from the time of burns. This is a key point over here. The second half, the next 50%, has to be administered in the next 16 hours, that is 8 to 24 hours post burns. The fluid used, and you're asking you what is the fluid of choice in case of burns, then your answer will be Ringer lactate solution, that is the isotonic crystalloid, right? So always remember 8 hours from time of burns. If the patient arrives 4 hours late, first half in remaining 4 hours. So you have to remember within that 4 hours, whatever fluid which I calculated for 8 hours has to be administered. So always keep in mind it is the focus of fluids resuscitation is calculated with the help of or with the time respective to the burns occurred, not time respective when you receive the patient. And here comes the most important slide. This is the updated fluid resuscitation formula. Right? So here you can see if the patient is a case of flame or scald burn and he is an adult patient and he's an older children whose age is greater than or equal to 14 years, then the formula is 2 ml of your Ringer lactate solution into your body weight into the percentage of total body surface area. Right? Here you have to remember. Okay, the update is in case of flame or scald burns, then the formula is going to be 2 ml into kg per into your percentage of total body surface area. And you have to remember whenever you're giving a good amount of fluid to the patient, you're doing a fluid resuscitation, rapid fluid resuscitation, the targeted urine output should be 0.5 ml per kg per hour, and it is a very, very important nursing responsibility to look after it. Next, the same case, if it is a flame or scald burns and it is a children whose age is less than or equal to 14 years, then the formula is 3 ml of Ringer lactate solution into the body weight of the child and the percentage of total body surface area, which is 1. And the expected urine output or the target urine output which you have to monitor is 30 to 50 ml per hour. The same case if it is a flame or scald burns and it is an infant and an young children whose age is less than or equal to 30 kg, then the formula is same, that is 30 ml of 3 ml of Ringer lactate solution into the body weight into the percentage of total body surface area. And you have to remember in case of infant and young children, we are going to continue with the maintenance dose of dextrose solution in order to prevent hypoglycemia. Right? So here the target urine output will be 1 ml per kg per hour. Right? So the important note, if the patient is a case of electrical burn, okay, on all ages, irrespective of all ages, and he has gone to 3rd or 4th degree burns, then the formula is same as your old formula, as you can see, 4 ml of your ringer lactate solution into your body weight, into your total body surface area, percentage of total body surface area. So here, what is the expected or targeted urine output? That also it is very, very important to remember. When the solution administration is increased to 4 ml, obviously it's a common sense. We are expecting the urine output to 1 to 1.5 ml per kg per hour until the urine is clean, right? So this is a very, very important update that you have to learn. So next, coming back to the fluid timing, as we have already discussed, right? 50% has to be administered in the first 8 hours. The rest 50% has to be administered in the second 8 hours, right? Second 8 to 16 or 8 to 24 hours. So here we have another formula. Once I given with the crystalloids, okay, once I'm given with the crystalloids, now I have to shift the patient to the colloids, right? So for colloids, we have a different formula. Colloids formula includes your Muir and Barclay formula. Okay, this is the most common formula used for colloid administration. So what is the formula of total colloid administration, right? So the body weight into your percentage of total body surface area divided by 2, right? Your body weight into your total body surface area divided by your 2. So volume of ml, okay, volume per ml, which you have to give to the patient will be calculated with the help of this particular formula. So here you have like how you're going to administer. So once you calculate the colloid administration, so how you will start from 2. So you'll be equally dividing that colloid into 6 parts, and you will be giving in this particular interval. So for example, we are giving the answer is 6,000 ml, right? So 1,000 ml for first 4 hours, 1,000 ml for 4 to 8 hours, and 1,000 ml for 8 to 12 hours. Same way for all these periods specific to the time you'll be administering, and you'll be dividing this fluid and you'll be administering. All right. And always remember, colloids have to be given only after first 12 hours. As you all know, if you are going to give the colloids before 12 hours, remember, after 12 hours, slowly, this interstitial space fluid will be restored back to the intravascular space. But before 12 hours, they are going to stay in the interstitial space only, and the capillary permeability is also increased. So at that time, if you're going to give colloid, what is going to happen? It is going to again leak into the interstitial space. So in order to avoid that only, initially we are giving crystalloids, then we are coming back to colloids, right? As I said, your colloids are larger molecules. So if you're going to administer larger molecules in the initial phase, this larger molecules, because of increased capillary permeability, they're going to leak into the interstitial space, and they're going to cause severe form of edema. To be classically known, you have to remember there will be an increased risk of pulmonary edema, right? So obviously, albumin leak also will be there, and this will be leading to reduced oncotic pressure. That's where which is leading to protein extravasation also, right? And we also have another formula for pediatric population, that is your Galveston's formula, right? So that is your 5,000 ml per meter square of your body surface area burnt plus your 2,000 ml per meter square of the total body surface area in 24 hours. You will be calculating and you will be administering, right? So this is not that much important, but you have to definitely remember about your Parkland formula, and that is widely tested in your competitive examinations, as well as your teacher will expect this particular answer when you're writing about bronze, right? So again, we have a quick review on your total body surface estimation with the help of your Welley's rule of 9, right? So here it is very, very easily given for you. Head and neck, okay, head and neck, both, okay, including your front and back, that is your 9%. Your right upper arm, including your front and back, that is your what? 9%. So I think the image it will be very, very clear. So as I said, you head and neck together, front and back, that is 9%. You can see here it is 9%, including your front and back, right? And here you have your right upper limb, okay, right upper limb and left upper limb. So Front side is 4.5 or 4.5%, and back side is also 4.5%. You see, front side is 4.5%. Yes, front side is 4.5 and back side is 4.5. Altogether, one arm will be 9%. So we have two different arms, right and left arm. So next, coming back to your anterior trunk. So here is your anterior trunk, okay? The chest region and the abdominal region. Together, it is what? 18% in the front alone. In front alone, right? So again, in back, together, it is 18%. This is in the back. This is very, very easy to remember, right? And for your genitals, which is present in the front, it is 1%. And for the lower extremities, remember, for upper extremities, the anterior part is 4.5%, the posterior part is 4.5%. Altogether, one arm, you are telling it is 9%. Okay, both front and back. Easily remember this. But in case of your lower limb, the anterior alone is 9%. So comparing anterior and posterior, it will be 18%. Right? Anterior and posterior in combination, it will be 18%. This clarity is very, very important. Right? So we have covered this rule of 9. And next we are going to talk about your Lund and Browder chart. Okay. So as I said, your Lund and Browder chart is considered to be the most efficient and a gold standard method to identify the TBSA estimation. Right? So accounts for age-related differentiation and according to the body proportion and more accurate when comparing to your rule of 9. So head at initial stage, at birth, it is 19%. After, as the age progresses, okay, proportionally, okay, the percentage of head is reduced. Okay, for lower limbs, it is increased proportionally with age, but head, it is decreased proportional to age. Okay, this is a classical point, okay, that you have to remember. Then it is best used method in clinical practice and in examination questions. But the most important thing is in examination, mostly they will be asking about Parkland formula only. If at all they were specifically giving that you have to calculate with the help of Lund and Browder, then you have to do it. But they will be giving you the image, most probably. Okay. So coming back to the Lund and Browder chart, as you can see, here they have drawn these lines, which is categorizing this particular area, and they have given the percentage of total body surface area which you have to cover. For example, okay, if it is an infant, the head is calculated. See, A is head, which is clearly given. Okay, the head is calculated as 9%. Okay, for anterior. For, see, this is anterior and this is posterior, right? This is anterior and this is posterior. As you all know, head is 9%. Okay, sorry, 9.5%. Okay, and this is also 9.5%. 9.5%. So anterior plus posterior, it is 19%, right? Anterior and posterior altogether, head is 19%. That's what they were telling. In Lund and Browder, proportionally, the head's percentage is decreasing. So when you go for adult, they are telling anterior is 3.5%, posterior is 3.5%. See the drastic reduction in calculation, right? So this is how Lund-Browder chart is working, and this is the other calculation which is coming. B area is targeting the thighs, C area is targeting the legs, and here you can see the upper arm, only the anterior aspect is 2. Okay, the lower aspect, okay, the distal portion is 1.5, and for the palms and fingers, they are again giving 1.5. Like that, based upon the marking, okay, they are calculating the total body surface area, right? So next is the immediate discussion on what is the difference. Village rule of 9 is used in case of adult population. Here, Lund-Browder is used in all age groups, including pediatric population. Accuracy is moderate, but accuracy is very high in case of Lund and Browder. And quick bedside estimation can be done with the help of Village rule of 9. That's why it is mostly preferred. But here in Lund border, we require the chart and we have to do the marking that this is the burnt area. And if that is the case and the patient age he is an adult, then the thighs is 6.5%. Like that, we have to calculate with the help of a chart, right? And in case of NORCET, what will be the primary focus? For quick estimation, if they're asking, then your answer will be rule of 9. What is best or gold standard or classical if you're going to ask, then your answer will be London Broader chart, right? So coming back to the burns management in wound care, right? So what you have to do initially for a burns patient, you have to wash the wound. If it is a first degree burn, okay, it is a superficial burn, then what you have to do, you have to wash the wound with soap and water, with cool room temperature water, not iced water, okay? And this is going to cause vasoconstriction, and also it will cause severe irritation when they are not having the exposure to that cold water, right? Do not burst blisters. If the blisters are present, we should not burst the blisters. And intact blisters act as a biological dressing protecting the wound. That is the reason we are not bursting the blisters. Avoid intramuscular or subcutaneous injection because already everywhere fluid is distributed. And obviously, when you are going to administer intramuscular or subcutaneous injections, already it is an injured tissue. What will happen? The absorption of the particular medication will not be that much efficient. So insert NG tube if the total body surface area of burns is greater than 50%, because there is a lot of chances the patient can go for paralytic ileus in case of a large total body surface area burns. So obviously we have to secure the NG tube. As you all know, burns patient will be in the state of hypermetabolic state. So it is very, very important you give adequate amount of nutrition in terms of proteins. So we have to secure the NG tube. So elevate burned limb above the heart level, which can reduce the edema formation and further pooling of fluid into that particular region. Right? So here, what are the dressing material preference? Again, the most important slide. So remember, first degree burns, no dressing is required. Okay, you have to expose the wound because you have to wash the wound with soap and water and you have to expose the wound, right? Okay, if at all the patient needs analgesic, we are going to administer analgesic if the patient is having pain. So second degree superficial burns. So here the choice will be your Vaseline or paraffin gauze dressing or collagen dressing if the area is non-infected. So what is the frequency of changing it? Changing it every 3 to 5 days, and moist healing you have to allow, right? And second, deep burns. In case of superficial burns, the choice is different. In case of deep burns, you're going to use hydrocolloid dressing. Okay, the brand name is deodorant we are using, and collagen dressing we are going to use, right? So next is third and fourth degree burn. Severe burns, obviously we have to do early excision, your grafting you have to do, and you have to allow the wound to heal, right? We are going to learn about this grafting in detail also. So next is the topical antimicrobial agents which you are specifically using for burns. The most common agent, as you all know, your silver sulfadiazine 1%. Okay, what is the primary advantage? Broad spectrum coverage, okay, of bacteria, and effective specifically against your pseudomonas and gram-negative organisms, like it has given proven result against this particular bacteria. So limitation is it will not penetrate the eschar. If the patient is having an eschar, this particular silver sulfadiazine, what it is going to do, it will not penetrate the eschar and do that, right? And whenever you are administering silver sulfadiazine, frequent changing of dressing is required. So next is silver nitrate. Silver nitrate is used less commonly. Okay, this is also having a broad spectral coverage, but it stains, okay, which causes blackish stains. That is your silver nitrate. Okay, it stains all the tissue into blackish color, right, making it so inconvenient for administration. And eschar penetration, as we have studied, Sulfur-sulfur-diacean is not having that much good penetration into eschar, but your mefenite acetate, 5%, is having a good penetration effect into the eschar also. They penetrate into the eschar and they are effective in deep and infected burns to clear the bacteria. So limitation, painful on application, a very, very important concern. Which of the following is most painful? Mefenate acetate is very painful on administration. Okay. And this particular drug can cause metabolic acidosis because it is a carbonic anhydrase inhibitor and they can significantly cause metabolic acidosis. And if they're going to ask you what is the best overall agent, then your answer will be cerium nitrate. Okay, this is going to be the superior most antimicrobial drug which is used in burns management, and it is going to also have an immunological effect, and it reduces eschar formation also. So less widely available in the clinical setting, but that is the best when comparing to other drugs, right? So the most important part you have to learn is about escharotomy, and important definition of eschar, why we are going to do escharotomy. The indication is very, very important for your competitive examinations. So as I said, your escharotomy is a surgical incision which we make through the burns eschar to release the compartmental pressure, which means it so much stiffened, the tissue is adhered. At the time, what I'm going to do, I'm going to do a small incision and I'm going to release this. So when I'm telling the tension is so much, it is pressurizing. Or in case of a circumferential burn, all over my arm, there is a burns. Obviously, because of fluid accumulation and third spacing, even more my arm is going to get bigger and bigger. The pressure is going to get increased and increased, right? So in that case, we are going to do escharotomy. So always remember, compartment pressure when it is becoming greater than 30 mm of Hg. Okay, so that pressure when it is becoming 30 mm of Hg, greater than 30 mm of Hg in a circumferential deep burns, then that will be the classical indication for your escharotomy, right? Yes. So let's see about the nutritional support in burns. Okay, so we are running out of time, right? Yes, we'll complete it faster. So here we have, in normal adults, we require the calorie of 20 to 25 kilocals per kg per day. In case of severe burns, as I said you, it is an hypermetabolic state. So we require 40 kilocals per kg per day for the population who is affected with burns, which means 2x the normal requirement. So protein calorie, minimum 20% of total daily calorie is required for normal. Okay, for the burns patient. And carbohydrate ceiling, maximum 5 mg per kg per minute. Okay, you have to maintain the carbohydrate level. And if it is going to become excess, that is going to cause severe hyperglycemia. Okay, and this is one of the another key point. When there is a peak nitrogen loss in burns patient, from day 5 to day 10 post burns, there will be a peak nitrogen loss. So here we have the Davis formula for protein requirement calculation. For children, it is 3 gram per kg plus 1 gram per your total body surface area burned. For adult, it is 1 gram per kg plus 3 gram per percentage of total body surface area burned. Right? So this is very, very important to be remembered, Davis formula. Right? And another important, and this will be the last slide. Okay. So causes of death in burns. So immediate causes within few hours, if the patient is dying, primarily it is because of asphyxia. Okay. So that is the most common and immediate cause of death. Later, in first few hours, if the patient is dying, it can be a neurogenic shock because of massive thermal injury or carbon monoxide poisoning in an enclosed room fires. So early, from day 1 to day 3, if there is a if there is a death. So hypovolemic shock is the reason because of massive capillary leaking, as you all know. So we have a term here called acute kidney injury. As you all know, acute kidney injury is classified into pre-renal, intrarenal, and post-renal. So pre-renal primarily occur because of lack of blood supply to the kidney. Pre-renal, which means the problem is before the kidney, which means the kidney is not getting adequate perfusion. That's why the kidney nephrons are damaged and it is leading to acute kidney injury. And next is carbon monoxide or cyanide toxicity with delayed presentation can cause death in day 1 to 3. So late death, okay, late death or overall most common death. So septic shock is the most common overall death because of infection. The patient will go for septic shock. That is the most common cause of death in patient with burns. And most common organism which is involved in septic shock is your Pseudomonas aeruginosa. That is also a very, very important point. Most common organism which is causing septic shock, and that is the most common overall cause of death in burns after day 3, right? And secondary organism which includes your Staphylococcus aureus, the favorite bacteria, and gram-negative bacilli. Yes, almost we have came to the end of our presentation, and I hope the session was really useful and effective for you to understand the most important burns management. Right, as we are running out of time, sorry for dragging this much, Okay, and thanks for being with me till the end of the session. Thank you so much.
Okay. Now, here's the thing. Even after understanding the concepts, a lot of students struggle with exams. Why? Because strategy is missing. And that's exactly what we are going to focus on next. We have with us our Margdarshak, Ms. Stuti Singh. She will guide you on how to actually translate preparation into marks. Ms. Stuti, ma'am, over to you.
Thank you, Nandini. I hope I am audible.
Yes, you are.
ओके गुड इवनिंग एवरीवन सो जैसे आपको पता है कि बर्न मैनेजमेंट अभी आप मैम ने पढ़ाया ये एक सिर्फ क्लिनिकल टॉपिक नहीं है एग्जाम पॉइंट ऑफ व्यू से इसमें 2 to 3 क्वेश्चंस एवरी ईयर पूछे जाते हैं तो सिंपली क्वेश्चंस नहीं आते हैं समटाइम्स सिनेरियो बेस्ड क्वेश्चन भी आते हैं तो आपको जो मेन पॉइंट्स हैं जो ध्यान देने हैं वो रूल ऑफ 9 पार्कलैंड फॉर्मूला डिग्री ऑफ बर्न फर्स्ट स्टेप कॉम्प्लिकेशन लाइक शॉक या हाइपोवोलेमिया उस टॉपिक्स पे भी आपको ध्यान देना है एंड द मोस्ट इम्पॉर्टेंट इज नर्सिंग केयर आपको एयर मैनेजमेंट फ्लूइड एंड यूरिन आउटपुट कैसे करो इनको आपको क्या करते हैं मोस्टली नॉर्सेट में एक सिनेरियो दे देते हैं उसमें आपको पूछते हैं आपको प्रायोरिटी बेस्ड क्वेश्चन पे भी ध्यान देना है एज मैं आपको बताती हूँ कि जिस ऑल द स्टूडेंट्स जिनका भी प्रीलिम्स क्लियर हो गया है मेंस लाइक 30s को है तो उसके लिए सबसे पहले आपको क्या करना है कि जो भी टॉपिक्स आपने पढ़ रखे हैं सिर्फ आपको वही रिवाइज करने हैं लास्ट मिनट जो भी आपने रिवीजन नोट्स बुक बना रखी हैं आपको वही रिवाइज करना है और एक ऑथेंटिक जो रिसोर्सेज हैं एमसीक्यू प्रैक्टिस प्लीज आप उसी से ही कीजिएगा क्योंकि लास्ट मिनट आप कहीं पे भी नई चीजों की प्रैक्टिस करेंगे तो पक्का श्योर आपको डाउट्स होंगे साथ में प्रॉपर स्लीप लेनी है और अपने हेल्थ का बहुत अच्छे से ध्यान रखना है आपकी प्रिपरेशन बहुत अच्छी है सेल्फ कॉन्फिडेंस रखिए अपने ऊपर सिलेक्शन पक्का है थैंक यू
Thank you so much, ma'am. That's what a student needs right now, motivation. Okay, and now something every aspirant needs. Not just theory, not just strategy, but real experience. We will now hear from our NORCET rank holder who has already gone through this journey, Miss Puribi Paul. Listen carefully here because these insights are the difference between preparation and selection. Miss Puribi?
Thank you so much, ma'am, for giving me this platform for sharing my experience. My name is Purvi Paul. Currently, I'm working in AIMS Devghar. I have ranked 351 in NORCET 9. First, I'll thank Ms. Priyadarshini ma'am for the amazing session on burns and burns management. For my experience, during NORCET, I was subscribed to the NNL Mastermind C Plus plan, and I have prepared throughout my NORCET journey. I have prepared from this plan only. The teachers are the best according to me because whatever concept I was lacking, it was all clear during my preparation by our mastermind faculties. And I would like to thank Mr. Deepak sir, Dr. Deepak Marva sir for the extraordinary medicine classes. Thank you, sir. And then I want to share that during the preparation, I have focused mainly on the recorded lectures and the uh, practice test that was given in our Mastermind C Plus plan. I have tried to attend all the lectures by our Mastermind faculties, but I couldn't attend 100%. Around 70 to 80% I completed. And I have followed the Intellect Saunders book for theory and the Mosby book for question practice throughout my preparation journey. And one thing that is the revision is very much important for our preparation. So whatever I studied during the lectures, I made the notes and I tried to revise the notes of 15 days or in 1 month. I did not delay the revision. Revision is very much important. All the practice tests that are given in C plus, I tried to attend all them. And during practice test, I made a review book and I wrote all the wrong questions that I got wrong. I wrote all of them, and then during the during next before the next test, I studied all the wrong questions that I did wrong, and then I attended the next test. I mainly focused on practice of mains because, according to me, it was prelims was easier to me than mains. So what I did, I sat for 3 hours. Weekly 2 times, I did the mains mock test, and after that, I took 3 more hours. After taking a break, I took 3 more hours for reviewing the mock test that I given. And the review of the mock test is very much important because whatever I do wrong or you are doing wrong, you will review it and then you will know what is in which area you are lacking the concept. Then after that, I identified my lacking areas. Then again, I go to the lectures that is in the app and clear my concepts. And one more thing, the preparation for main there is difference in the mock test and preparation for the main exam. So you have to prepare for the real exam. So you must sit 3 to 4 hours without any disruption and prepare for the mains exam, because that is the most important thing for your ranking. Prelims is uh, relatively easier because in prelims there are more students are getting selected, but in mains you have to secure a good rank for your preferable aims. I mainly focused on the clinical subjects like fundamentals of nursing, adult health nursing in medicine and surgery, OBGYN, pediatrics, psychiatry, community medicine, and pharmacology. These were the main subjects that I focused during my preparation. And one more thing, the Intellect Saunders book, uh, I use the Intellect Saunders books for my for a reference book during my preparation, and whatever Marva sir teaches, it is in the book, and whatever in the book Marva sir teaches us that. So that was very good for my preparation. And also, I'll say that the hours are not important according to me, because whatever you are studying, you need to study that you need to clear your concept in every topic and appear for the exam in that topic, appear for the practice test in that topic. If you have any practice book that is given by NNL, you can try that, or otherwise there is Mosby and Saunders also. And the practice test, the subject wise practice test is also very good for preparing for clearing the concept in topics and subjects. I mainly studied I will say 6 to 8 hours during my preparation, and I completed my whole revision. 15. I started my total revision 15 days prior to exam and completed it 3 to 4 days prior to exam. And after that, I did not appear. I did not practice any test or mock. I only revised the notebooks that I prepared from the lectures. And after prelims, do not waste any time. Do not wait for if you are clearing prelims or not. Uh, just after prelims, take 1 day rest and start for the mains. That is what I did. And That is most important thing, I will say. For community medicine, the live classes that are given in faster classes, that was very helpful for me during NORCET 9. And this is the mostly thing that I did during my preparation. And thank you, Nandini ma'am, for giving me this platform. And thank you all.
Thank you so much, Ms. Purvi. That was really informative. Let's continue with the session now. Okay, students. Also, a quick update for you all. For those who prefer offline structured preparation, NNL Academy is now available in Bangalore. It is designed for students who want proper guidance, consistent discipline, and a competitive environment. So, if you are someone who feels self study is not enough, this could be the right step for you. We are offering two modes, offline learning and as well as virtual learning. If you are aiming for NORCET 11, then this is the right place and the right time for you to enroll in this and start your preparation. This is the infrastructure of our Bangalore Academy. You can see the images, what all we provide. We provide CBT labs, we provide lectures, we provide classrooms. These are few reasons why should you join us. We are running short of time, so you can quickly go through these pointers. And then we have our academic heads, Ms. Priyanka Bansal ma'am, who is Chief Academic Officer. Then Ms. Priya Darshini Balan ma'am, who is Academic Head of Bangalore. And then Mr. Muthu Kumaran sir, who is Academic In Charge, Bangalore. This is the subject coverage strategy which we follow in our NNL Academy. You can go through this. You can explore more details after this session. These are few feedbacks which our students gave after every classroom, after every lecture. Okay, now it's your turn. If something is unclear, so don't carry your confusion forward. You can ask your queries, your questions in the chat box. So we will pick the most relevant ones and we will try to answer your questions. If anyone has any query, kindly put that in chat box. Okay, we have one question for NORCET. Which one to use in NORCET, old Parkland or new modified if they don't mention specifically? Ms. Priyadarshini ma'am, kindly answer this question.
So this is a very hypothetical question, which we have to use. So, based upon my expertise, I would advise you have to look for the keywords. Either it is a flame or scald burns, or it is an electrical burn, or the degree of burn. Either it is third or fourth degree. In those cases, the formula is not going to change. In case of electrical burns or in case of third and fourth degree burns, right? The formula is going to be same as old formula, that is 4 ml of ringer lactate into the body weight of the patient into the percentage of total body surface area. So, but if you have given with proper specific age groups and it is a flame or scald related burns, then you have to modify the formula. Right. We are expecting, if at all they are going to give the question from burns, they will be targeting the updated formulas only, because most of the cases it is always mixtured here. Like if there is an update, the answer key can be for the updater or it can be for the old version also. So always read the question properly. Try to fetch some keywords so that you can sense either they are asking you the old formula or new formula. Like in the scenario itself, you can able to come up to the conclusion.
Okay.
So for
Thank
tracking
you so much,
NORCET,
ma'am.
many students are asking about how much time I have to spend, what is about Plan C plus, right? So Plan C plus, those who don't know how to utilize Plan C plus effectively, we already have good number of videos which is telling about what is available in Plan C plus and how you have to study using Plan C plus. If you go to NNL1 YouTube channel, you can see a lot of videos which is indicating about Plan C plus. So seeing those videos, you can come up with a very good idea like how you have to utilize plan effectively. And the most important additional information is, if you are a working professional, Plan C is the best go. And if you're a non-working professional, you are a fresher who is looking for conceptual clarity, then you have to take a coaching from a academy, okay, which has given the proven results. And the most important thing is, for the very first time, NNL Academy Bengaluru has been opened, and this is our first South head office. And as you all know, there's many students from the South, they want the classes completely in English. In NNL Academy Bengaluru, our masterminds are completely taking the classes in English. Okay, this is a very, very important thing to note, as a carry message you have to take. Once people who are targeting for studying in completely in English, you can join NNL Academy if you're going to plan, if you're planning for full time into preparation.
Yes,
Gujarat
ma'am.
Coaching
Very well
Center.
said. Yeah. Okay. We will take one
No, in
last
Gujarat we
question.
don't have an NNL. And the most
Yeah, for
important thing
that you
is,
have to
if at
come
all
to
you can't
Noida.
able to commute, yes, I'm telling you, if you can't able to commute, you can't able to come to Noida, okay, if you can't able to come to Jaipur, Edu Hub also, if you can't able to come to Bangalore also, you have another option that is termed as your mastermind live batch. Okay, that is MLB live batch. If you put in your Chrome under NNL, you can see. So currently NNL is coming up with, is going live with MLB Mastermind Live Batch of Pearl. Okay, in that you need not to come physically present in the classroom. Sitting in your home with the help of an app, you can see all the live classes. You can follow all the curriculum in your home also. Okay, if you want many information, please connect with the helpline numbers which is given in the website so that you can get a clarity. Okay, thank you so much for joining with us. Yes, over to you, Nandini.
Okay, we will take up one last question. Bill has asked that. Just a moment. Should we use target high for Norset or Saunders? Because I have target high. Nidhi, you can use target high as well because it summarizes every topic. If you have target high, you can use that. If you study that properly, like throughout, you can definitely crack the exam. You don't have to use many other books. Just focus on one single book, what you are from which you are studying. Focus on one book rather than focusing on multiple books. Okay.
Okay. If you have personalized query, you can
My
also
screen is
connect
visible
with
to us?
me through our. You can connect with my
Yes.
Instagram profile, that
So
is Nursing
students,
with Priya
kindly,
Balan. You have personalized guidance. And yes, over to you.
yes. So students, kindly scan this QR code and attempt the quiz. From this only you will get the chance to win our Masterstroke Volume 3 book. So it is very important to scan this QR code. Kindly take a picture of this or scan this QR code. You have few seconds. Only few students will get the chance to win the Masterstroke Volume 3 book, depending on the quiz you attempt. Okay, so before we wrap up, just remember this: in emergency care, hesitation cost lives. In exam, hesitation cost marks. So build clarity, practice decisions, stay consistent. Thank you for being such a focused and involved audience today. I hope this session genuinely helped you Move one step closer to your goal. This is Natini Paul, and I will see you in the next UDAAN session. Take care and keep preparing smart. Thank you all the panelists also for being such informative and guiding our students throughout.